So now we are talking about ARDS, acute respiratory distress syndrome. The MCQ related thing is there is some significant background event. It could be a surgery, it could be sepsis, it could be severe disturbance in the normal physiology, and then there is acute respiratory deterioration, decrease saturation, and increase respiratory rate. So, this is the whole picture of acute respiratory. Some significant event along with acute deterioration. Acute is important. What happens in ARS? As we discussed, the pathophysiology of high altitude pulmonary edema, increased permeability of alveolar capillaries leads to water leakage in the alveolar spaces. So, like, so this is non-cardiogenic pulmonary edema. Why increased permeability of alveolar capillaries? Hypoxia in the body can cause increased permeability of alveolar capillaries. Hypoxia is because of this stress in the background that we talked about, and then obviously due to this fluid build up in the alveolar space, the situation will be worse more. What are the causes of ARDS? Starting from head to toe, uh, I have just made this very bad looking person. But from top to bottom, if there is any fire, smoke inhalation, near drowning. So I need to correct this as well later. Yeah, near drowning can also cause leakage into the lung, and uh, it can cause ARDS. So if we talk about organs, lungs, heart, pancreas, lungs, it can be caused by pneumonia. Pneumonia can settle into ARDS, COVID. The other, if there is any massive blood loss or if there is any trauma, I have just put it on the heart. Obviously, we know trauma, massive blood loss cannot or does not need to be from the heart. Just to remember something to do with blood loss, I have put it on the heart. Pancreas, acute pancreatitis, if we take both organs, cardiopulmonary bypass. So, causes of ARDS: smoke inhalation, near drowning, pneumonia, COVID, massive blood loss, trauma, cardiopulmonary bypass, burns, and obviously pneumonia, sepsis, or maybe any other source of infection leading to sepsis can lead to ARDS. So, clinical feature, we all know fluid will build up in the lungs, difficulty breathing, crackles, increase respiratory rate, decrease saturation. We discussed this. This is ARDS. Management, because of the acute pattern, we need to take the patient to ITU for intubation and ventilation, and 100% oxygen with some muscle relaxant and symptomatic treatment or treat the cause. Pressure controlled inverse ratio ventilation, high positive and expiratory pressure, prone position. So we don't need to remember this. The only thing is MCQ will say someone got a surgery a few days ago, now they are deteriorating. Saturation is 92 on 40% FiO2. What is the diagnosis? Acute respiratory distress syndrome. Someone got a recent COVID or someone got a severe infection and now they are in the ward for 2 days. Suddenly there is a drop in the saturation. What is the diagnosis? Acute respiratory distress syndrome. Investigation, simple full set of investigation for any cause that we know: culture, chest x-ray, blood, septic screen. The last bit is uh, that fluid buildup because of ARDS can increase elastic recoil of the lung. Because there is fluid buildup, there is decreased gas exchange because of that barrier of fluid between the blood and the alveoli. Lung compliance will be low and low pulmonary artery wedge pressure. So these are all the physiological changes that will occur in ARDS. Increase elastic recoil, rest of the things will be reduced. Reduce gas exchange, low lung compliance, low pulmonary artery wedge pressure. So that is ARDS. Now we know a significant event, acute deterioration. The diagnosis is ARDS. Move on to Let's move on to next topic.